Usually when we talk about a medical diagnosis, there's this comforting expectation of precision.
Right, like it's very cut and dry.
Yeah, exactly. It's like engineering. You break your arm, the x-ray shows that jagged white line, and the doctor just points to the screen and says, well, there it is. There's your problem.
It is incredibly binary. Broken or not broken, sick or healthy. I mean, we are wired to crave that kind of clarity because, we like our problems to be visible
Right.
and easily categorized. It just gives us a clear path to a solution.
But then you step into the world of sexual health and pelvic anatomy, and suddenly that x-ray machine is just completely useless.
Oh, entirely useless.
We're looking at a diagnostic landscape that is honestly incredibly murky.
Yeah.
And today I want to welcome you, the learner, to a deep dive that is going to pull back the curtain on this exact ambiguity.
It's a really fascinating area to explore.
It really is. We're looking at a stack of highly personal medical and sexual health materials today. We've got clinical data from urogynecology centers, insights from physical therapy journals, and research that's going to challenge pretty much everything you think you know about intimacy and anatomy.
It really is a space where physical symptoms, psychology, and the dynamics between two partners just completely blur together. You cannot look at just one piece of the puzzle and expect to see the whole picture.
Right, it's all connected.
Exactly. Sexual health is a complex, shared ecosystem.
Okay, let's unpack this. Our mission today is to tackle a deeply misunderstood topic, which is vaginal laxity. That feeling of looseness or, a loss of friction during sex.
A very common complaint, yeah.
Right, and women have been told for centuries that this is somehow a personal failing. Society frames it as a sign of aging or the inevitable cost of motherhood or even like the result of having too much sex. But we're going to drop the core, provocative question of this deep dive right now.
Let's hear it.
Could a woman's perceived vaginal laxity actually be a case of her partner's unrecognized erectile difficulties?
And that is the pivotal question. When we analyze the clinical data across these materials, we find that sexual dysfunction is rarely a one-sided, isolated anatomical issue.
Because of that shared ecosystem you mentioned.
Precisely. Because it's a shared ecosystem, one partner's physical state can directly mimic or even completely mask the others.
It's wild to think about. To understand how a partner's anatomy could literally trick a woman into thinking her own body has somehow changed shape, I feel like we first have to understand the baseline mechanics of the vagina.
That's a great place to start.
And we really need to dispel this incredibly persistent, damaging myth that the vaginal canal can be permanently stretched out just by having regular intercourse. I mean, I see this myth everywhere, and it completely misunderstands human biology.
It completely ignores the physiological reality of the tissue. I mean, the materials we reviewed describe the vagina not as a static, rigid tube, which is how people often visualize it, unfortunately.
Right, like a PVC pipe or something.
Exactly. Not like that at all. It's actually a highly elastic, active, muscular canal. And the walls are lined with these folds of tissue called rugae.
I was trying to picture those, and the best analogy I could find was the pleats on an accordion.
Oh, that's good.
Like, they are compressed when resting, but they have all this built-in slack.
That is a perfect visualization. The rugae are made of specialized connective tissue and a mucosal layer. So when a woman is unaroused, the canal is actually quite compact, roughly 2 to 4 inches long, and the walls have collapsed inward, basically resting against one another.
Okay, so it's small at rest.
Right. But during arousal, there is a massive shift in local blood flow. The folds of the rugae physically smooth out, and the canal actually lengthens.
Wow.
Yeah, it can expand to 4 to 8 inches or more,
Yeah.
and the walls relax to accommodate whatever is inserted. Gynecologists refer to this as the tenting effect.
The tenting effect. So it is actively adapting. It's an active physiological response, not just a passive empty space. I like to think of it like a very robust rubber band. It stretches to accommodate pressure, but the baseline nature of that tissue is to rebound and snap back into place afterward.
That's a very accurate way to look at it.
But I do have to push back here for a second, because if we're saying it's this perfectly elastic rubber band, why do so many women report a very real, tangible loss of tightness over time? Like, are they just imagining it? What about major life events like childbirth or aging?
Well, they absolutely aren't imagining it. And it's crucial to distinguish between temporary accommodation, like we just talked about, and actual structural change.
Okay.
The research is definitive that frequent intercourse or the physical size of a partner do not cause permanent looseness. that elasticity absolutely holds up. However, major physiological events do cause real structural changes.
Like childbirth.
Yes, let's look at childbirth. A vaginal delivery, especially with a large baby or if there's significant tearing, can push that tissue beyond its elastic limit.
So the rubber band actually frays a bit.
Exactly. It can physically stretch and sometimes permanently damage the underlying pelvic floor muscles and the fascia.
The fascia being the connective tissue.
Right, the connective tissue that holds everything together.
Yeah.
And that results in a real physical form of laxity.
That makes total sense. You're dealing with intense mechanical force there. And then there's menopause, which I found fascinating in these materials because it's a completely different mechanism of laxity. It isn't mechanical at all. It's chemical.
Precisely. As we age, and particularly during perimenopause and menopause, a woman's estrogen levels just plummet.
And estrogen is key here.
It's the crucial hormone. It binds to receptors in the vaginal mucosa to stimulate cell turnover, blood flow, and collagen production. It's basically what keeps those tissues plump, thick, and resilient.
So without estrogen, the tissue literally loses its structural scaffolding.
It does. You get a significant loss of collagen. The vaginal walls actually thin out, sometimes becoming quite fragile, honestly, and you lose that baseline elasticity. It's a well-documented condition called genitourinary syndrome of menopause, or GSM.
Okay, so we've established that childbirth trauma and estrogen loss during menopause are real, verifiable anatomical culprits for laxity.
Yes.
But here's the major pivot for our deep dive today. Let's imagine a scenario where a woman hasn't recently given birth and she hasn't entered perimenopause.
Okay, her baseline anatomy is intact.
Right. The structural integrity of her tissue should be fine. But suddenly, over a period of months, she's feeling a distinct lack of friction during intimacy. She feels loose. Where do we look?
Well, we have to stop looking at her.
Wow.
We have to look at the other half of the equation. We have to evaluate the partner.
Here's where it gets really interesting. I was digging through the clinical files from a urogynecology center included in our stack, and this one specific directive just jumped off the page.
What did it say?
It said, quote, "Before assuming your vagina is the issue, ensure that your partner can achieve and maintain a good erection."
It's such a vital piece of advice.
It's a profound paradigm shift. I mean, when friction decreases, society has conditioned us to assume the container has gotten bigger, rather than asking if the object inside has gotten softer.
If we connect this to the bigger picture, it really just comes down to the basic physics of friction.
Okay, break that down for us.
Friction requires two solid surfaces exerting normal force, basically outward pressure, against each other. If the male partner's erection isn't fully firm, like if it lacks maximum rigidity, it is simply not going to exert the same outward pressure on those vaginal walls.
And to the woman, that sudden lack of outward pressure physically translates as a wider space.
Exactly.
She feels less friction, she internalizes that physical sensation, and her immediate thought is, oh, something is wrong with my body, I'm too loose, I'm failing my partner. When in reality, she's experiencing a subtle form of erectile dysfunction on his end.
It is a tragic misinterpretation of anatomy. And we have to recognize that male erectile dysfunction, or ED, is highly misunderstood in our culture.
Because we think of it as all or nothing.
Right. We view ED as a total catastrophic inability to perform.
Right.
A binary, just like that X-ray analogy you used earlier. But clinically, ED exists on a very wide spectrum.
That's not always obvious.
Not at all.
Mm-hmm.
It can manifest as a very subtle loss of fullness, or just a difficulty maintaining maximum firmness consistently throughout intercourse.
And the male partner might not even fully realize it's happening, or, more likely he's just too embarrassed or anxious to mention that his erections have changed. So he stays quiet and she takes the blame.
Happens all the time.
But what I want to know is what's causing that ED in the first place? I was looking at the materials, fully expecting to see the usual suspects, heart disease, high blood pressure, low testosterone.
Your standard cardiovascular issues.
Exactly. But one of the major overlooked causes of ED highlighted here completely blew my mind, which is a hypertonic male pelvic floor. How does a muscle issue cause a vascular problem?
It is a brilliant mechanism to understand.
Yeah.
So a hypertonic pelvic floor basically means the muscles in the pelvis are overly tight. They are chronically guarded, essentially locked in a state of ongoing spasm. In men, this is often diagnosed as chronic pelvic pain syndrome, or CPCPPS.
I was trying to visualize the mechanics of this, and the best analogy I could come up with is stepping on a garden hose.
That's a great way to picture it.
Because the pelvic floor muscles, like the ischiocavernosus muscle, literally wrap around and support the base of the penis. So if those muscles are clamped down tight in a chronic spasm, they are physically compressing the pudendal arteries.
Yes.
The blood simply cannot flow fast enough or hard enough into the erectile tissue to create a fully rigid erection.
That garden hose analogy captures the arterial side perfectly.
Right.
But there is a second layer to this mechanism that's just as important.
Oh, really?
Yeah. On top of restricting the inflow of blood through the arteries, those tight, spasming muscles can also fail to properly compress the veins.
Wait, I thought we wanted the veins open.
Actually, no. Normally during an erection, specific muscles engage to clamp the veins shut, which traps the blood inside the penis to maintain firmness.
Ah.
If the pelvic floor is dysfunctional, the veins stay open, meaning the erection just drains too quickly.
So we have restricted inflow and uncontrolled outflow.
Exactly.
The man experiences a softer erection, entirely driven by his own tight pelvic floor muscles, and the woman feels the resulting lack of friction, and because of cultural conditioning, assumes she has vaginal laxity.
It's a domino effect.
She might be sitting at home researching expensive, invasive surgical vaginoplasties to fix a looseness that doesn't actually exist, all because he has an undiagnosed muscle spasm in his pelvis.
It highlights the absolute necessity of evaluating both partners before jumping to conclusions.
Truly.
But this brings us to another fascinating and slightly more dangerous layer of the diagnostic puzzle.
Let's get into it.
Let's say we check the partner. His pelvic floor is healthy, his erection is perfectly firm, 100% rigidity. The mechanical pressure is definitely there.
Okay, mechanical pressure is good.
But the woman still feels a distinct lack of friction. If her anatomy hasn't changed structurally, and his anatomy is functioning perfectly, what is the third culprit?
The nervous system. This is the part of the deep dive that starts to feel a bit like a medical thriller. I mean, I understand mechanics, but how can the brain and the peripheral nerves literally trick a woman into thinking her physical anatomy has changed shape?
What's fascinating here is realizing that our entire perception of our own bodies, our sense of space, pressure, touch, is entirely dependent on nerve feedback.
Right. Without nerves, we feel nothing.
Exactly. And the clinical guidelines we reviewed heavily emphasize systemic conditions, like diabetes-related neuropathy.
Let's break down the how there. How does blood sugar impact sensation in the pelvis?
Well, it's a slow, insidious process. Prolonged high blood sugar levels create compounds called advanced glycation end products.
Or advanced glycation end products, okay?
Right. And over time, these compounds damage the vasa nervorum, which are the microscopic blood vessels that supply oxygen and nutrients to your actual nerves. Yeah. When those tiny blood vessels are damaged, the nerve endings literally starve. They begin to misfire, and eventually they just lose their ability to transmit signals.
So we're talking about a gradual onset of numbness.
Yes. Numbness, tingling, or just a severely muted sensation. And it isn't just diabetes, by the way. Spinal nerve irritation can do the exact same thing.
Like in your back.
Exactly. If a woman has a bulging disc in her lower back, it can physically compress the sacral nerve roots that travel down into the pelvis. If those nerves in the vaginal wall aren't sending strong, clear signals to the brain interprets that absence of sensation as an absence of friction.
It's like trying to feel the texture of a finely woven piece of fabric while wearing thick winter gloves.
That is a brilliant comparison.
You run your hand over it, but you can't feel the ridges, so your brain just assumes the fabric is perfectly smooth. But the fabric hasn't changed at all. Your neurological ability to detect it has.
Exactly.
And a patient trying to rationalize that lack of friction naturally thinks, well, I must be wider, I must be loose.
That is exactly what happens. And this raises a massive issue regarding patient safety. The medical literature in our stack includes a very stark warning about misdiagnosis here.
Because the doctors might just believe her.
Right. If a clinician doesn't properly investigate why a woman feels a sudden lack of friction, they might simply take her at her word and send her down a cosmetic treatment pathway.
Right. They see a distressed patient and they sell her a vaginal laser treatment or radiofrequency tissue heating or even surgical tightening.
When in reality, she doesn't have a tissue problem whatsoever. She has a nerve problem. Assuming that less sensation automatically means structural laxity can lead to completely unnecessary, expensive procedures that won't even fix the issue.
Which is terrible on its own.
But even worse, it means the doctor completely misses the underlying neurological clues. That feeling of looseness might be the very first warning sign of undiagnosed, unmanaged diabetes.
Oh, wow.
Or it could be a spinal condition, that needs urgent neurosurgical assessment, especially if she's also experiencing things like lower back pain, saddle numbness, or sudden changes in her bladder or bowel habits.
That is wild to think about.
Yeah,
The symptom of feeling loose in bed could actually be your spine crying out for help or your pancreas.
it's all connected.
It just shows how deeply interconnected the human body is. You absolutely cannot isolate one localized symptom from the entire physiological system.
You really can't. And that theme of interconnectedness brings us to a massive contradiction in how we talk about pelvic health in popular culture.
Oh, I see where we're heading. The Kegel paradox.
Yeah.
If you read any women's health magazine or go on any wellness blog, the universal unquestioned advice for women is do your Kegels. Squeeze, tighten, strengthen the pelvic floor. The narrative is that tighter is always, always better. But the physical therapy journals we're looking at explicitly state that a tight pelvic floor can actually ruin a woman's sex life. How does that make sense? We just spent the last 10 minutes establishing that looseness and a lack of friction is the enemy.
It seems contradictory until you look at how muscles actually function.
Okay, explain that.
The pelvic floor is a dynamic muscular sling. It needs to be strong to support the organs, yes, but it equally needs to be able to fully, completely relax. When pelvic muscles are too tight or chronically guarded, we enter the territory of genitopelvic pain penetration disorder, or GPPPD.
I notice the clinical texts use that umbrella term now. That includes what used to be called vaginismus, right?
It does, yes. Vaginismus is a condition where the muscles around the outer third of the vagina contract involuntarily. They literally lock up.
Ouch.
Yeah, this can completely block penetration, or if penetration does occur, it feels like severe burning, stinging, or tearing pain.
Why the burning sensation specifically? Is that just the friction against the tight space?
It's deeper than that, actually. When a muscle is locked in a chronic spasm, it's working constantly. It demands oxygen, but because it's so tight, it compresses its own blood supply.
Oh, so it's suffocating.
Exactly. This leads to a buildup of lactic acid and metabolic waste in the tissue. So the burning pain isn't just friction. It is the literal chemical reality of a suffocating, spasming muscle. It's essentially a severe cramp, like a Charlie horse, right at the entrance of the vagina.
That sounds awful. And earlier we talked about how a hypertonic or tight pelvic floor in men causes erectile dysfunction and restricted blood flow.
Right.
So this obsession with having a tight pelvic floor is actually devastating for both partners' sexual health.
It really is. Healthy sexual function requires coordinated muscle relaxation. During arousal, the pelvic floor must relax and drop to allow for increased blood flow, engorgement of the tissues, and comfortable penetration.
So if you're tense all the time.
Right, if you are constantly doing Kegels at stoplights, constantly tensing and clenching, you're training your neuromuscular system to keep those muscles clamped shut.
And when they're clamped shut, intimacy causes pain. And the materials map out this really vicious psychological and physical cycle that happens next.
It is a terrible loop.
Pain creates anxiety. The next time you try to be intimate, you subconsciously anticipate that pain. That anxiety triggers a fight or flight response in your sympathetic nervous system.
And how does the body respond to fight or flight? It increases muscle tension to prepare for an attack.
Right. Your body literally braces for impact. So the psychological tension leads to even more physical tension in the pelvis, which leads to even more severe pain during sex, which just leads to more anxiety.
You're totally trapped.
You're trapped. And if you believe the cultural narrative, you might think the solution to your sexual dysfunction is to do 100 Kegels a day to tighten up.
Which would be catastrophic. It would be like trying to cure a clenched jaw by chewing harder.
Exactly.
The solution to this specific dysfunction isn't strengthening. It's learning how to let go. Pelvic floor physical therapists often recommend the exact opposite of Kegels. They teach what are called reverse Kegels, which involve consciously dropping, bulging, and relaxing the pelvic floor muscles.
I was reading about the techniques, and they often pair reverse Kegels with diaphragmatic breathing.
Yes, deep breathing is essential.
Taking deep, expansive belly breaths that naturally push the abdominal diaphragm down. Because the pelvic floor mirrors the diaphragm, right? So that pressure forces the pelvic muscles to lengthen and relax. It's all about unlearning the tension.
It is. And crucially, it requires addressing the root cause of that tension, which in modern society is so often chronic stress.
Just everyday stress.
Yeah, stress redirects blood flow away from the genitals, it spikes your adrenaline, and it causes people, both men and women, to unconsciously clench their pelvic floors while they are just, sitting at their desks, checking emails or driving their cars.
So what does this all mean? Let's zoom out and look at the massive picture we've painted today. We started with a very common scenario, a woman worrying that her vagina had somehow lost its shape, that she was too loose and failing her partner.
Right.
But by diving into the actual clinical science, we've dismantled that narrative completely.
We really have. We've found that perceived looseness is rarely a simple, isolated cosmetic issue of stretched out tissue. Unless, of course, we're looking at specific trauma from childbirth or the distinct hormonal shifts of menopause.
Right. Instead, that feeling of laxity could actually be a hidden struggle on her partner's end, a subtle erectile dysfunction caused by his own tight, stressed out pelvic floor cutting off his blood supply.
Exactly.
Or it could be a neurological mimic where early stage diabetes or a compressed spinal nerve is dulling her sensation, making her brain falsely assume she's wider than she is.
Well,
Or paradoxically, the problem isn't that she's too loose at all, but that she's too tight, caught in a neuromuscular spasm of anxiety and pain that just makes comfortable intimacy impossible.
the overarching lesson from all these materials is that sexual health is a window.
A window into what?
It is a highly sensitive indicator of your overall systemic health, your vascular blood flow, your peripheral nervous system, your baseline stress levels, and it's a reflection of your relationship dynamics. The biggest takeaway for anyone listening is that you shouldn't jump to self-blame or rush into expensive cosmetic fixes without evaluating the entire ecosystem.
You have to look past the murky diagnostic waters. And that leaves us with a final thought to mull over for you, the learner. A provocative idea that really builds on everything we've just discussed about tension and biology.
I love this thought.
If a tight, stress-induced pelvic floor can cause erectile dysfunction in men by cutting off arteries, and it can cause agonizing, impossible sex in women by triggering muscle spasms, could the ultimate, most effective sexual enhancement tool for a couple simply be finding ways to radically reduce each other's daily anxiety?
It makes perfect sense physiologically.
What if the best foreplay isn't physical at all, but just actively taking the weight of the world off your partner's shoulders so their nervous system can finally let go?
It's a powerful question. And it shifts the focus entirely away from fixing a perceived physical flaw and toward cultivating actual physiological safety.
Definitely something to think about. Thank you so much for joining us, The Learner, on this deep dive into the hidden realities of our anatomy. We hope we unpack the science in a way that gave you some real aha moments and a completely new perspective on how interconnected our bodies really are. Keep questioning the obvious, look at the whole picture, and we'll see you next time.
Remember, the human body is incredibly complex, but understanding it doesn't have to be. Until next time.